next eminent speaker is Dr. Prem Subramanian, who is the Chief of Neuro-Ophthalmology, University of Colorado, an individual of great standing, very prolific and experienced in dealing with the most complex of neuro problems, most complex of traumatic brain injury, and all else that comes with it. So he is going to be talking on something very relevant, diagnosis and management of traumatic optic neuropathy. On to you, Doctor.
Thank you so much for the opportunity to participate. So moving from the front to the back of the eye, we're going to talk about traumatic optic neuropathy. And the diagnosis really is a clinical diagnosis because frequently there are no other outward signs other than the vision loss. For example, this 24-year-old, he was an unrestrained driver in India. He might be driving a two-wheeler and was thrown regardless of whether he was wearing a helmet or not. And he struck his forehead. He lost consciousness for 15 minutes, and then he was stable and awake and alert and cooperative 2 hours later. And that's one important point I want to emphasize, is that the evaluation of an uncooperative patient or a patient who's otherwise head injured and making the diagnosis of TON can be challenging, more challenging than this, where he was clearly no perception of light in his right eye, normal vision in his left eye, had a big APD and amaurotic pupil on the right, and everything else was normal. This is the classic way in which a patient with traumatic optic neuropathy presents. And there are a few things that need to be done in the diagnosis to ensure you are not missing a more extensive injury, because this is a completely different category of patient from those you just saw, where there was clearly visible trauma to the eye. Here, there may be nothing. So what are you obliged to look for? Neuroimaging is important in these patients because it may identify things like an optic canal fracture. This is a different patient with a canal fracture on the left side, as pointed out on the axial and coronal CT images here. But you may see no fracture at all. Don't rely on this, because even if it's absent, you could most definitely still have a traumatic optic neuropathy. But in these patients, they have struck their heads typically. You want to ensure that they don't have other evidence of brain injury. Now, there's some controversy as to how frequently it is, looking at the other way, of those patients who have TBI, traumatic brain injury, how frequently they have optic neuropathy. And the reason I think there's some controversy is because the literature is different depending on how you look at this question. So if you look at patients who are referred to neuro-ophthalmologists, 326 patients sent from hospital units to the neuro-ophthalmologist, 8% of them had traumatic optic neuropathy. That seems like a huge number. However, if you take 200 patients with traumatic brain injury, just all comers, and that's what's shown in this graph over here, a typical distribution, mostly men, mostly young men, only 1 out of 200 had traumatic optic neuropathy. And of 5,700 facial trauma patients, 20 of whom had vision loss, only 1 had traumatic optic neuropathy. In a similar way, this question has been asked of patients with military-associated trauma. Here you see a study of US military veterans who were injured, who had either a systemic neurologic injury, as shown here, or traumatic brain injury. And what was found was that the incidence of optic nerve injury was 2 to 3 times higher than controls who didn't have a systemic neurologic injury or traumatic brain injury. So when you are evaluating a patient with vision loss, you should be concerned that they may have traumatic brain injury. But the reverse of that is that if patients have had head injury, there is a chance that they will have traumatic optic neuropathy, but the incidence is not that high. So again, clinical diagnosis, do a good examination. The examination, other than an RAPD and vision loss, though, may be unrevealing in the early phase. I'm not going to go into the utility of things like OCT and visual fields in the early detection of traumatic optic neuropathy, because OCT basically has no role, and if their vision is so bad, they're not going to be able to do visual fields. So what are we going to do as far as treatment of these patients? What's the evidence? I know that many people will choose to give corticosteroids in patients who have traumatic optic neuropathy. And these data come from over 20 years ago, a non-randomized study where patients were allowed to be observed, randomized to steroid, or get surgery, which I'll get to. And the conclusion of this study was all three groups had some degree of improvement, they were indistinguishable, and you should do whatever you want. That's not really good data, and that's not very helpful to us. So what else can I tell you? Well, just before I go on to anything else to discuss as far as evidence, remember that in this study, when you let physicians randomize patients to whatever treatment arm they want, there was an overrepresentation of no light perception patients in the surgical group, which could easily bias the outcome, bias the results of what was seen in this particular situation. And I'll show you some more examples of how bias enters into our interpretation of all of these data of how to treat these patients. Because they have a terrible injury, right? You've heard trauma patients start out normal and suddenly have a very bad thing happen to them. It's natural to want to improve their vision. So in 2015, there was a review that was done saying, is there treatment for traumatic optic neuropathy? And the conclusion was there is still no reliable evidence. Now, subsequent to that, or before I go on to that, there are two different kinds of steroid treatments that are used. One is the ONTT type of steroids, 1 gram intravenously given daily for 3 to 5 days. That one was given in the ION or the traumatic optic neuropathy study that I showed you. Now here, there had been a previous study, spinal cord injury study, where megadose steroid, 30 milligram per kilogram loading dose, and then 5.4 milligrams per kilogram per hour for 23 hours was given, and it helped spinal cord injury patients. But then when it was tried on head injury patients in the study aptly named CRASH, this showed not only there was no benefit for this megadose steroid, but there was increased mortality. This graph on the right is not from CRASH. This graph on the right is from animal studies of a crush injury traumatic optic neuropathy, where animals were given either saline or this megadose of steroid. Who did best? The ones who were given saline. Megadose steroid actually seemed to make retinal ganglion cell survival worse. So steroids may not only be unhelpful, they may be harmful when given at mega doses. We still don't know about the 1 gram per day. A Cochrane review. Cochrane reviews look to gather all the evidence and come up with a recommendation based on rigorous analysis. 247 studies, various types of case reports, retrospective case series, et cetera, for steroids and traumatic optic neuropathy were identified in 2007. Expanded search in 2010 showed 501 articles, but then they pruned it down to get rid of redundancy and found 378 references. They were screened for duplication, study design, and outcomes. They found one study that actually met criteria for scientific rigor. And that one study is shown here, where 31 patients were randomized, truly randomized, to steroid 1 gram per day versus placebo IV infusions. They were all seen at the 3-month endpoint, and you can appreciate there was a vast range of outcomes in both groups, but there was no statistically significant difference between the final visual outcome of the two groups. That's the only randomized study of steroids versus placebo that's out there to guide us. Well, how about steroids versus surgery? I mentioned that surgical decompression of the optic canal can sometimes be done to help patients with traumatic optic neuropathy. And this was a somewhat randomized study of 30 patients, 12 of whom got surgery and 18 got steroids. And what their raw data show is that there was no significant difference in improvement. So many more patients, for whatever reason, got assigned to surgery in the light perception versus no light perception group. But nonetheless, they found that ultimately patients before and after treatment, there was no greater chance of improvement if you had surgery versus steroid. Now, again, there was no control group to see if this treatment actually did anything at all, but surgery and steroid, at least in this study, seemed to be equivalent. There was an open label study of steroid versus erythropoietin, which has been shown to be neuroprotective in multiple sclerosis, versus observation with 100 eyes included, treated within 3 weeks of injury. Very important, has to be acute and age 5 or greater. This is the bottom line. While the patients who were given drugs seemed to improve more quickly than those who were observed, the final outcome at final follow-up was no different among these 3 groups. So unfortunately, none of these medical treatments seems to be particularly effective. There is no Cochrane review of surgery because there aren't enough randomized clinical trials. Surgical treatment consists of 2 treatments: optic nerve sheath fenestration, where there is intra-sheath hemorrhage, as shown in this particular case right here, where it may be helpful to relieve that compartment syndrome, but this can be very difficult to diagnose. The more commonly done surgery is endoscopic optic canal decompression, where the canal is open, the bone is removed, and then the dural ring is opened, as shown here with a sickle knife or MVR blade. There have been some series that I'll quickly go through in the interest of time, where patients were treated with surgery. And unfortunately, some of the data, as shown here, show that there was not great effectiveness of surgery, particularly in patients with no light perception, and that operating more than 13 days or 10 days after injury resulted in really no improvement at all. And perhaps earlier surgery was better. It didn't seem to make a difference whether there was a canal fracture or not. In a much larger
So you have 1 minute remaining.
Looking at patients with endoscopic decompression, the majority of whom had a canal fracture, they were given surgery if they didn't respond to medical therapy, as shown here. Those patients who had a canal fracture had a worse vision to begin with, but after surgery, all of them seemed to improve. But again, they had been treated with steroid first, and amongst the groups, there did not seem to be any difference in the likelihood of improvement with surgery, regardless of whether they had an optic canal fracture to begin with or not. So I'll finish by just saying patients, at least in North America, who get traumatic optic neuropathy seem to be prone to more optic neuropathy because they do stupid things. They are generally young men who injure themselves again. And in a series of 12 patients over 18 years who were treated for their initial traumatic optic neuropathy had visual recovery, when they had their second traumatic optic neuropathy, regardless of what you do, they did not recover vision. So the final point I will leave you with is prevention of subsequent injury in our trauma patients is critical. Patients with traumatic optic neuropathy often have some improvement, but are visually impaired in the injured eye, and we don't have good ways to help them. And secondary prevention, eye protection, refraining from risky behaviors is one of the most important things we can advise our patients in these situations as their ophthalmologists. Thank you very much for your time.
Thanks a lot, Dr. Prem. As usual, was so clear and succinct in whatever you said. You were talking about compartment syndrome. Just that, is it some earlier intervention, like immediately doing a canthotomy or inferior cantholysis and all that? Do they have a significant role to play when you think there is a compartment syndrome?
Sure, I didn't mention orbital compartment syndrome. I was talking more about optic nerve sheath compartment syndrome, but absolutely, if you think that there is a markedly elevated IOP, there's restricted globe movement, a compartment syndrome there, definitely canthotomy, cantholysis would be advisable. Low risk, potentially high yield.
Why is it that the anatomy of the optic nerve, what is it about this anatomy which influences traumatic optic neuropathy?
So we didn't have time to go into that, but there are cadaver studies and animal studies that suggest that the cone shape of the orbit concentrates energy at the orbital apex and at the optic canal. And so a blow to the forehead transmits a shock wave along the orbital roof, and then it is amplified and concentrated at that point, making the nerve vulnerable there. That seems to be the basis.
Oh. Srinivas, you have anything to ask?
Wonderful talk, Dr. Prem. So for the general ophthalmologists who are watching this, what is your cutoff point? Do you advise steroids or no in case of traumatic optic neuropathy? And at which point do you advise surgery? Just in simple words.
Sure. I have shifted away from giving steroids. I almost never give steroids just because there is so much evidence against it. And also, more importantly, I'm concerned about making a potential brain injury worse. So that's why I don't give steroid. If I'm going to do something, I will do surgery, but it should be within 3 days, is what I advise by a good, talented endoscopic surgeon.
What's your cutoff range for the vision in taking up for the surgery?
Sure. I tend to reserve it for those patients who are counting fingers or worse.
Thank you very much. Yeah, we could go on endlessly asking you a lot of useful questions. Thanks so much, Dr. Prem, for setting aside your OPD to be with us in this time of your day. Thank you very much.
Thank you.
Thank
Thanks
you.
a lot.
Thank you, Dr.